Okay, folks, we're gonna do a quick finish up to the spine series, where I just wanted to touch up on a last piece of information where we discussed the concept of driven equilibrium. And specifically, when we talk about driven equilibrium, we're talking about this concept of one of the few freebies in MR, where we can preserve contrast or keep a short enough TR period and still gain excessive enough or bright enough signal from fluids. So where we apply it, especially we see in turbospinecto or fast spinecto applications, where we can achieve brighter signal from CSF, brighter signal from fluids. We also utilize this in MRCP applications as well. Take a look at the difference between the two. Without drive, take a look at CSF. It's kind of gray on this T2 weighted sequence. Turning drive on, this driven equilibrium pulse, now you have brighter signal from CSF. On Siemens magnets, this is restore. I'll be sending you guys a file that'll be attached to the link to this recording, where you'll be able to access the information regarding this. We're going to switch off now to the other lesson. If you would turn to lesson 11, and we'll continue with advanced imaging, breast, and cardiac MR. So with this, we're finishing up our last section or segment, and we're going to be discussing the concept of breast MR. Breast MR has grown tremendously in recent years, but especially over the last 5, maybe 4 years or so, when breast density legislation has increased. Women with dense breast, diagnosed with dense breast on mammography, can now have ultrasound and MR with better insurance approvals. Only in the last year or so has there been less of a utilization in MR of the breast, because it is a very expensive diagnostic modality. As we talked about last week with the breast MR, last week we talked about prostate MR, where we use CAD. So that's a rapid T1 spoil gradient echo with fat suppression to aid and increase our tissue contrast. We do the same thing in breast, but it's more strict because we have to acquire our dynamic scan time in under a minute 20 to a minute 30. In order for the CAD computer-aided detection to perform its work in achieving the exponential time curves, basically that wash in and wash out rate. So it's crucial for us with speed, and then also, again, the same recurring theme as we've been discussing in recent weeks, the shimming is crucial in achieving optimal homogeneity. So just a crucial portion of our work in getting the most homogeneous scans that we can acquire. Now with that, it's really important with breast MR to ensure that the patient is changed completely, that they're free from any metal. The power injector is a 1/2 meter from the edge of the magnet. All of these tips and tricks to ensure the best imaging possible. We use breast MR for extent of disease, so staging, monitoring their response to therapy in breast cancer patients, and then also screening those at high risk for breast cancer. Any BRCA or BRCA positive genetic testing can lead to very rapid insurance approval and doctor's order for a breast MRI. Anytime we're imaging breast MRI, it has to be with and without, or in order of events it would be without and then with the injection of contrast, in order to see lesions that have enhancement properties to them. Only breast MRI that's utilized to rule out implant rupture or tear would be performed or imaged without the injection of contrast. Breast MRI can, according to the literature, change treatment plan in 15 to 30% of breast cancer patients. Bright T2 images are usually benign. Why are they usually benign? They're more cystic in nature. Again, T2 bright, we look at as being high edema, high fluid content. So lesions that are bright T2 are usually cystic or cystic based in nature, fibrocystic breast, and so on and so forth. Two main methods of approach in imaging. You have the axial method, which covers bilateral breast in one plane, or the Porter method of imaging, which is sagittal acquisitions. Sagittal acquisition, as far as MRI of the breast, can be very lengthy scan times. So you can always tell which place is scanning axial versus sagittal by the length of their breast MRI protocol. For us here in this facility, we actually scan bilateral breast MRI with and without contrast, with diffusion, and we acquire this in approximately 10 to 12 minutes of actual scan time. It takes us longer to screen, set up, place the IV than it does to actually image the patient. So you want to utilize dedicated breast coil. More elements gives us, the user, the opportunity for parallel imaging options. The parallel imaging technique, or accelerator, is a method that uses the coil to reduce the workload of the phase encoding gradient. Purpose of that is we can reduce dynamic scan time, and that's crucial to get that spoil gradient echo with FATSAT, to get that dynamic scan time to be around a minute 20, even possibly a minute 10, but definitely no more than a minute 30 per dynamic run. We run one pre-contrast, make sure we have homogeneous, even, uniform FATSAT. Once we inject the contrast, then we run 3 or even 4 full dynamic acquisitions post-contrast. And once that's sent to the CAD software system, then it will be able to determine with the radiologist plotting specifically a region of interest or an area of interest that is suspicious. They can now get the wash-in and wash-out rates. These are known as exponential time curves. We're able to establish the aggressive nature of a more malignant lesion, and this is all based on the color scales, if you will, that the CAD software will generate. Biopsy or localization procedure capability, increased signal to noise with dedicated breast coil, and also increased detail capability helps to achieve immobilization of the breast. Consistent and homogeneous FATSAT, and that's one of the keys to this, is getting consistent FATSAT all the way around. Dedicated breast coil disadvantages: reduction in patient clearance and the bore of the magnet. One of the tricks that we use often is to place a wedge under the legs to lower the upper body. Watch for your parallel imaging artifacts. As we increase our reduction factor, we get centrally located artifacts which identify them as being parallel imaging artifacts, as opposed to wraparound, which occurs at the outer edges and works its way in. Parallel imaging starts in the middle and works its way out. So just that you can differentiate artifacts and the source of where those artifacts do occur. Fat suppression uniformity, again, is critical. So do not inject the contrast until you have ensured that you have uniform, homogeneous fat suppression across your image. And there'll be some various volume shim suggestions that we'll look at shortly. Power injector connection, obviously set up to the IV with a flow rate that you want to keep consistent. So 2 mLs per second, and then weight-based contrast dosage. You want to keep that flow rate consistent across all patients so that the CAD has an expected rate of contrast entry and discharge through a region of interest. So you want to keep that flow rate consistent. Any variations from your norm, your established flow rate, has to be documented in the patient's chart and notified to the radiologist that they can change the settings on the CAD before issuing their report or having it perform its calculations. So that CAD is all important. One last note I meant to put in the slide. Please do not exceed a 512 matrix so that the CAD systems are able to perform their functionality. Very often, most commonly, the errors that occur with a CAD that's unable to process is because the matrix or the reconstruction matrix has exceeded a 512 matrix number. Separate non-contrast protocol for implant rupture or integrity. We'll look at the difference between saline and silicone tissue types, especially how they look in MR and what our peaks are going to look like, and we'll talk about that. And that's where we'll utilize small field of view sagittal sequences. One little point when doing breast MR, tissue expanders. So tissue expanders are devices that are implanted in women that have already had a mastectomy, and are undergoing treatment before they have a full reconstruction. If they haven't had any breast surgery, they won't have a tissue expander in, and for the most part, they're going to be temporary, so they're not permanent entities. But always, especially when imaging for a female for breast MR, ask the question whether or not they've had tissue expanders implanted. Any mastectomy, ask if they've had a tissue expander, as they are MR unsafe. They can turn or torque inside the patient, or they can actually burn. There are two documented injuries to patients as a result of tissue expanders. So again, whether or not the implant is placed above or below the pec muscle is an anatomic variant based on implanting surgeon's preference, and again, some of the normal breast anatomy. In a patient with saline implants, you have the overall anatomy where the mammary ducts, the fatty tissue, lung behind it, and then the chest wall. The implant, the pec muscle coming down. Again, muscle is always dark on T2, where fluid, in this case, saline is always bright, and the liver tucked in behind it. In a 7-channel coil, notice all the clearance that's taken out of the actual magnet. A lot of effort is being made in research into coil development in reducing this amount of clearance loss inside a magnet. So keep in mind the differences between your breast coil types. So take a look. The all-important portion of a breast MR is to utilize these shim boxes. And in employing the shim boxes, we're looking to achieve the most homogeneous fat suppression that we possibly can. And that's crucial to get the best images possible. Sometimes it doesn't work consistently, especially if you have older women. You have a lot of air tissue spacing that can really wreck your homogeneity of fat suppression. So some people will actually take their shim box and place it just over the sternum so that you're getting as much tissue as possible with as little air as possible. I used to work with a tech years ago who used to place the shim box only basically over the liver, which I thought was a little unusual, but it worked pretty successful for her. So other techniques, only using one breast if that's the one that's not fat satting. So other methods of achieving that. So we do a good shim. We have a dynamic scan time here in this example of 1:04. So we want to keep that dynamic scan time each run under 1:30, closer to 1:20, but definitely not to exceed 1:30 in all types. So how do we know whether or not we're ready to inject? We ran our sequence. Here's our MIPT image. But most importantly, we have a homogeneity to our overall fat suppression. There's a uniformity here, which is our end goal, is ensuring that there's consistency to our fat suppression, that there's not an area of drop-off. As we looked at, I think last week or the week before, that quadrupole artifact, you don't want to see a whole quadrant out compared to the rest of the image. You want to make sure that you have a uniformity, a homogeneity before you administer the contrast injection. So you have a good injection. What's the first thing we look for? When our first run reconstructs, you want to see bright contrast within the heart, and now you're able to proceed with the remainder of your exam. So let's take a look at what a normal breast MR should or could look like. Always we start with the overall anatomy sequence. So there's a T1 axial. Your overview of breast tissue, field of view, should always be large enough to cover all pertinent breast anatomy, so that you're sure you're covering all the appropriate tissue. When there's a mass, take a look. We're going to go back one. Normal tissue, you can see a lot of bright fatty tissue, just normal tissue as you go throughout. And you see this mass-like structure, obviously one breast larger than the other, large mass obviously impacting not only size but also the degradation of tissue. Here you have this kind of multi-density interface, if you will. And as we go through, look at the contrast enhancement. You have a pretty excessive enhancement, a very bright signal. How do I know this is post-contrast? You have contrast on the heart and then contrast throughout the tissue. So multi-density, it could have some solid component, some bloody component, maybe some cystic with it, but definitely an enhancing lesion. When you look at the MIPT images, again, MIPT is just a collapsed composite of all the slices we obtained, and then you see the bright signal. Very easy way to identify where you have positive enhancement. Sometimes it doesn't have to be a mass that large, obviously, so you have just a medial left breast mass, but again, the enhancement is pretty consistent where that gadolinium is that T1 shortening of the tissues it interacts with. Kind of the three-plane MIP reconstruction where you can see exact location, especially good for biopsy planning. And then again, you have another mass in this patient's right breast. T1 dark is usually the more solid mass structures with fluid as well. And then most systems are going to allot the opportunity for water and fat. And when we center on water, we suppress the signal from fat. Now on Phillips magnets and GE as well, water's on the left, fat is on the right. Keep note that Siemens actually puts water on the right, fat would be on the left, so it's backwards than what we're showing here. Please keep that in mind as you go through your scan planning and your comparing systems. So here the system came up with our center frequency right in the middle. How do we fix that? We want to move it over so that we're centered on water, and then the signal from fat would be suppressed. As we talked about chemical shift establishes a difference in the precessional frequencies of both fat and water, where fat and water at 1.5 Tesla are separated by 220 hertz. It's about 147 hertz per Tesla. At 1.5 Tesla, you have a 220 hertz separation between the tissues of water and fat. When we're performing the art or the craft, if you will, of achieving homogeneous fat suppression, we want to ensure that we're centered on water so that our signals from fat are indeed suppressed. Sometimes we're only going to shim on one side because we're struggling with the homogeneity of fat sat, so that may be an idea as well. And then when we have the contrast, we want to establish an ROI in an area where we see enhancement to a lesion, and we want to see the overall exponential wash in and wash out rates. Is it washing in completely? Is there a wash out component to it? What is the effect of comparing the lesion to also tissue outside that lesion? And then what would the CAD, the computer aided detection, say about that lesion when we put it into those software mechanisms? You see areas of red, that indicates a hypervascularity. So you have an aggressive malignant component to it as compared to the blues and the greens that don't have as an aggressive blood supply to them. So always red indicates areas of hypervascularity. You'll see it in blood vessels as well, as the heart is really red here, but the areas of red are those that are indicated as being hypervascular or more malignant in nature, as the CAD data, computer-aided detection, would indicate. The only way this is accomplished is a dynamic scan time that's around a minute 20 or less, but definitely under a minute 30. Also, we do breast MR for implant rupture. So in this case here, we're going to utilize posterior presaturation to block off not only respiratory motion, but also cardiac motion as well, to aid in the reduction of flow artifacts and artifacts from respiratory and cardiac motion. Left side is always going to be more predominant with expected flow artifacts that you could see here. As you can see, comparing the right to the left, definitely more predominant when you look at artifacts. It's probably the only indication where we'll do coronal imaging, would be assessing for potential implant rupture as well. So it's really the only indication where we'll perform coronals in a breast MR. And then of course STIR or T2 fat sat, we want to have good homogeneous fat sat. So giving contrast, sometimes what you want to do is trick the system. When you do your shimming, especially if it's going to be a silicone breast implant, you want to trick the system into almost telling it that that tissue type almost doesn't exist, so that you can get a good homogeneous fat suppression throughout your region of interest. Saline implants, T2 very bright, so T2 very bright and T1 dark because it's a highly fluid containing substance. So saline tends to be very T2 bright, very T1 dark. And then when you go to inject contrast, again, same thing. You want to make sure you have a good, homogeneous, even fat sat so that your subtractions come out very nice and that your MIPT images are able to see the vascular enhancement throughout the breast tissue. Silicone is completely different. Silicone adds a third component to your shim, and we're going to explain that in a second. Very often we see sites just doing a over the sternum only in the medial portion, shim placement so that they get really good fat set because of the disruption of silicone. What's the first thing that jumps out at you when you look at the peaks in a patient with silicone implants? First thing that jumps out at you is that you have 1, 2, and now third peak. So this is adding an additional tissue component to your shim functionality. So you go to perform the function of active shimming. We place the good volume shim. We're including as little air as possible. All of these tips and tricks of the good MR tech. And what happens? The system's showing you 1, 2, 3 peaks. So what I want you to kind of know and understand about it, and again, on Phillips magnets, water is always left. On Siemens, it would be on the right. So water to fat, and then always, do you have a 220 hertz separation between water and fat? You're going to add 93 hertz at 1.5 Tesla. Adding 93 hertz is where silicone is found. And again, this is just the processional frequencies, the chemical differences of the spin speed, the attributes of the different tissues. So silicone always lives 93 hertz farther than fat from water. So again, 220 hertz separates water from fat. An additional 93 hertz is the separation distance of silicone relative to the distance from water. And I hope that makes sense. So silicone peaks, for us on the Phillips magnet, you want to center as left as possible so that the fat and silicone signals are going to be adequately suppressed. When there is silicone rupture, there's a difference in signal intensity. So when you see the difference in signal intensity, that's indicating the presence of rupture. Silicone-only sequence is that's designed with brighter signal from fluids. When you have brighter signal from fluids, that's a silicone-only sequence. When there's rupture, that's going to give you darker signal intensity or gray ISO intense to the bright silicone-only. When you do the silicone suppression sequence, this is a double to a triple inversion recovery sequence, and now what that does for you is it suppresses the signal from silicone. But again, same concept. There'll be variations in signal intensity in indicating the presence of rupture of that implant. What makes or breaks, or what really is concerning to the referring physician, is whether or not the implant rupture is intracapsular or extracapsular. So whether or not it's contained within the implant or it's leaked out into superficial or surrounding tissues. So that's a huge diagnostic component, why especially in implant cases we want to make sure that we cover axillary tissue. So again, in the presence of rupture, you see variations in signal intensities. When there's variations in signal intensities, that indicates abnormal tissue. Silicone suppression versus silicone only. Sagittal imaging, silicone only, and again that brighter, darker signal indicating rupture. Injecting contrast, same thing, the subtraction, and then our MIPT imaging as well. Some QA. What's the problem here? What's the issue? A patient not screened properly for a tissue expander. How do you identify a tissue expander? Extremely large voiding artifact from susceptibility artifact. The susceptibility artifact is there's an active device, there's a magnetic port in her chest that indicates the presence of a tissue expander. Not screened properly, we go to start the exam, and there's the artifact from the non-MR safe implant. What happens if you center on the wrong peaks? What happens if for the technologist who works on Siemens all week long and comes to our place on the weekend and centers on the wrong peak because he's been working on Siemens all week? Silicone suppression is not obviously suppressed signal. Silicone only is not bright signal, where you expect to see bright signal from silicone. So those are the wrong signal intensities when we centered on the wrong peaks. As we talked about in our motion correction section, when imaging for the sternum, you want to use the breast coil, because what that's going to do for you is that's going to give you optimal signal intensity throughout the sternum. You're going to get the breast tissue out of the way. The patient's already going to be prone in the magnet, so you're going to have zero concern with respiratory breathing motion. You're going to have excellent SNR throughout just this region of interest. Highly suggest, it's not really in the books, it's not really set in stone, but highly suggest in the presence of a sternum, or in the example of a sternum order, you want to utilize the breast coil, male or female, so that you get signal elements directly on the area you're imaging, and you eliminate the possibility of respiratory or breathing motion artifact. Small field of view, 2 millimeter slice thickness, usually just sagittals and coronals are all you need, and then a 3 millimeter axial slice thickness. Again, options, breast coil versus torso, but you always want to do the patient in the prone position. So again, chemical shift, and especially when you look at the implant imaging, silicone, chemical shift, the frequency difference between fat and water, 1.5 Tesla, 220 hertz difference. 1 Tesla, you're looking at 140 hertz difference. Why? They contain different components. They both contain hydrogen, but fat is made up or comprised of carbon and hydrogen, whereas water is hydrogen and oxygen. Therefore, they have to have variations or differences in their precessional frequency. When you look at chemical shift artifacts, those chemical shift artifacts can only occur in our frequency encoding direction. So chemical shift artifacts, when you're seeing areas of white and dark within the same imaging plane. So in this case here, when you have this white in the back here and then dark in the front, this is an indication of chemical shift artifact that's occurring in the A to P direction. So what does that mean for you? That means that the phase direction is superior to inferior, because the frequency direction is opposite to that, which in this case here would be AP. The only way to eliminate this artifact, which this is not real, the only way to eliminate this artifact is to image the patient at lower field strength. It's the only way to eliminate the chemical shift artifacts in MR. So chemical shift is expressed as parts per million. This is identifying the homogeneity of the magnet, measured in ppm or parts per million, and equals 3.5 parts per million. One method that you could use to reduce some of that chemical shift artifact is to employ wider bandwidth techniques. But again, just watch that it can affect or have an impact on your overall signal in your image. So how would you calculate that 3.5 parts per million and equal or sum to your overall hertz of chemical shift? It would be 1.5 Tesla magnet, which is 42.56 megahertz per Tesla, times 3.5 times 10 to the power of negative 6, was 223 hertz at 1.5 Tesla, or 3T times 42.56, so that would be obviously our 127, times 3.5 times 10 to the power of negative 6, is 445 hertz, or 440 hertz is the estimator at 3 Tesla. So ways that you can calculate that 3.5 parts per million and translate that into your hertz of chemical shift. So again, higher field strength will lead to increased opportunity for chemical shift artifacts. Lower field strength would be the way to do that. If you wanted to actually calculate water fat shift, this may be one of your trial questions on a potential registry examination. So we're going to go over this rather quickly. Don't stress too much about this, and we'll talk about this on Monday when we do a little recap. Let's look at it. 1 Tesla, the difference in precessional frequency is 147 hertz. Approximately 220 hertz at 1.5 Tesla. As field strength increases, so the frequency difference of chemical shift also increases. So in order to calculate the exact pixel shift, or if you wanted to know exactly how much chemical shift is going to be in my image, what can I expect? The factors necessary are bandwidth, and specifically I mean frequency bandwidth, field strength, and the matrix used in the sequence. Okay, so bandwidth, field strength, frequency matrix. So if the bandwidth is 26.8 kilohertz, you will see this terminology often. 26.8 is your overall kilohertz, but your bandwidth may be expressed in simply plus or minus 13.4 kilohertz. Because again, everything that we talk about has positive and negative polarities, right? So if it's only expressed as plus and minus 13.4, please note that your total bandwidth is 26.8. And you have a frequency matrix of 224. The system used is operating at 1.5 Tesla, so 220 hertz of chemical shift. The model to calculate the amount of pixel shift would be this. 26.8 is bandwidth in kilohertz, times 1,000 to convert into hertz, because we want everything to be matching denominators. So 26,800. We're going to take 26,800 and we're going to divide by 224. Please keep in mind this is our frequency matrix. When we talk about chemical shift, we have to be denoting the frequency matrix, not your phase matrix. So 26,800 divided by 224 equals 120 hertz frequency difference per pixel. This is how Siemens denotes bandwidth. This is how, and if you just do 26.8 kilohertz, that's how GE terms your bandwidth. Now 220 chemical shift divided by this 120 hertz equals 1.8. That's your answer. The fat image will be shifted 1.8 pixels along the frequency or readout axis relative to water. Philips terms water fat shift of 1.8 as bandwidth. And we know that the smaller the water fat shift, that's actually a larger bandwidth that's utilized. And that's simply the way that you can calculate the water fat shift. An example and a little bit of math that everybody, including myself, despises. So, why is it important to even know that there is a chemical shift? There's an awesome technique at our disposal called MR spectroscopy. Take a look at this MR spectroscopy. Agree, this is a little bit of an older slider image, but it gets the point across. You're not looking at ISO intensities. You're not looking at bright or dark signal intensities, what's hyper, hypo intense, bright fluid, dark fat. You're not looking at any of that. Simply put, spectroscopy is a graph-like readout of chemicals, or what we're going to term as metabolites, that are detected within a VOI, or a volume of interest. We set a particular three-dimensional box, and then we tell the system specifically, this is the area that I need you to image in. It's a non-invasive method. So this does not require contrast. It is spatially selective, and we're looking at biochemical reactions. We can look at several metabolites. This is one of the most awesome slides. This is basically telling you the resonance frequency is the point along the scale where the chemical is found. The height of the peak, it corresponds to the amount of the substance detected. Full width, half mast is here. And then your integral. So I'm going to show you some slides and we're going to look at it. Spectroscopy can be single voxel, where you pick one box, or it could be multivoxel, where you have multiple boxes within an entire slice or region of interest. So spectroscopy can be used in the brain. Here's a multivoxel application. We have a heavy amount of presaturation that's used, and selective saturation is really the method of getting rid of all surrounding tissues. I'm only looking in this area right here. It can also be used in the prostate. Starting to see some spectroscopy for liver and also for breast in development. So creatine in the brain, N-acetyl aspartate. This is not a sugar substitute. This is a compound found in the brain that's an important control for us. Also lactate. So at the different parts per million is where these substances are found on the scale. So in a multivoxel application, where there's multiple graphs or readouts within a particular slice that's been obtained. In single voxel, we're doing one specific region of interest. So this is a gentleman that came to us repeatedly for tumor evaluation. And keep in note one thing, isotropic is super important in spectroscopy. So our VOI, volume of interest, is 20 by 20 by 20. So we have a 2 centimeter by 2 centimeter by 2 centimeter volume of interest. Within that volume of interest, it's important for you, the technologist, when you plot this box, to do a few things. Number one, ensure that it's always going to be isotropic. Number two, avoid air, avoid bone, and avoid blood or fluid. You don't want to have things that are moving within that area, if possible. You don't want to have air, and you don't want to have bone. So you want it to be in brain tissue itself. Notice we're just medial to that midline there, and we're also just superior above the ventricle there. It's okay if you have a little bit of edema. You mainly want to be in the area where the tumor itself is housed so that you can get a result. The press technique is the most common technique that's used, and the shortest TE possible results in more metabolites that are detected. So if you have an option of a TE of 288 compared to a TE of 144, go with the shortest TE possible to achieve more metabolites that are detected. So what does it give you? Again, we have our images here where we planned and plotted our slices. And one of the things that we look at is the comparison of choline versus creatine versus NAA. That N-acetylaspartate is our control. Notice that choline is here on the scale, NAA is here on the scale. So the point where these metabolites are found on the scale corresponds to the frequency, whereas the height of the substance corresponds to the amount of that substance that's been detected. This is the area of the tumor, and then we always image the contralateral side or the opposite side. And I want you to take note of one thing. You see this right here? This is called the hunter's angle. Picture a bow and arrow. He's going to shoot a bow and arrow at whatever. He's hunting, right? So normal hunter's angle means that the amount of NAA or N-acetylaspartate that's detected is far greater, ratio-wise, than the amount of choline that's detected. I'm going to go back to the gentleman's area where the tumor is. Do you see the amount of choline is far greater than the amount of NAA? This is a perfect display or a perfect indication of what's known as a choline spike. So this is basically indicating for you that there's malignancy found in this particular region of interest. This is a reversal of the hunter's angle. That choline spike, far greater than the amount of NAA that's detected. This indicates potential for malignancy. And then again, compared to the contralateral side, NAA, when the NAA is higher, that's normal tissue or negative for malignancy. Patient that we follow, a kid actually, they were looking to do a biopsy. The parents did some research and they wanted to do spectroscopy instead of having to put a needle in their child's head, basically, right? Non-invasive method. What do we find? The amount of choline compared to the amount of NAA. Perfect hunter's angle. No need for anything that's malignant because the amount of NAA, the normal tissue, is far greater than the amount of choline. There is no choline spike. Hunter's angle. Contralateral side, same thing. Normal hunter's angle. That positive find in that area that was suspicious is confirmed as being benign, just very simply by a non-invasive method of imaging. Patient with recurrent tumor and seizures who has spectroscopy performed, multivoxel as well. And same thing, the amount of NAA is far greater. Through the region, NAA far greater than the choline. Mesial temporal sclerosis, seizure disorder in patients. We looked at this when we looked at the brain content. MR spectroscopy in the region of interest. MR spectroscopy on this side, on the right side, and now you have a choline spike. I'm going to go back one. On the patient's left side, temporal lobe, NAA higher or even to choline, so that's okay. On the patient's right side, right through the hippocampus, right? Amount of choline far greater than the amount of NAA. Basically, you can give this patient all the anti-epileptic seizure medications, and nothing will work until they do a temporal lobectomy to correct for the recurrent, possible constant seizures the patient's having. Perfusion MRI. So perfusion MRI, in contrast to spectroscopy, does indeed require the injection of contrast. Perfusion is microscopic blood flow in cerebral capillary and venules. We want to see the amount of hypervascularity, okay? Again, red tends to indicate increased capillary blood volume in tumor. Specifically, what we look for is the amount of vascularity in the edema around the tumor or within the actual tumor itself. So MR perfusion, what are the types? I know we talked about this a couple weeks ago. What are the types of perfusion? Perfusion simply indicates a rapid injection of contrast, or a way that we can look at the viability. How much blood volume is there? So one of the main methods that we utilize often is DSC, where it's dynamic susceptibility contrast, or T2 star. This is reliant upon rapid dynamic imaging, 1 to 5 seconds per dynamic. We want to look at cerebral blood volume, CBV, and signal loss or dark signal is actually what indicates our pathology. We're going to compare this to DCE, which is simply stands for dynamic contrast enhanced, or T1 perfusion. Where do we do T1 perfusion? Think prostate MR. Think of our normal abdomens. Think of breast MRI with those dynamics we just talked about. Where now, because T1 decay and the process of T1 recovery, takes a lot longer, we're looking at the process of T2 gradual decay as opposed to the T2 star rapid decay. So we're allowed to have a little more freedom of time to image, for lack of a better term. So we're going to look at 15 to 90 seconds per dynamic. Hyperintensity to the region of interest is what indicates hyperperfusion. Pituitary hypointensity indicates microadenoma. So here's where we want to limit the dose to avoid overintensification of the gland. And then another method of perfusion that's gaining a lot of steam lately is a non-contrast method of acquiring perfusion data, and this is called arterial spin labeling. We place the tags, in quotes, on the patient's own water molecules as tracers and use that to obtain information on perfusion. So what do we define perfusion? As a means to establish vascularity of a given process. We're comparing that to an internal reference, or normal appearing white matter. And RCBV is the main method of the proportionality of neovascularity, or capillary density. Tumor from non-tumor, brain neoplasm from secondary lesions. We can grade gliomas with this. Also to differentiate tumor recurrence from radiation necrosis. Very effective. Obviously, will increase the treatment plan or management plan, and also confidence based on this data. Protocol for our T2 star perfusion: we have to inject at 4 mLs per second. Our time curves are generated on a separate workstation, and we want to use this normal appearing white matter as our control. We want to compare that to abnormal tissue. So normal tissue, good enhancement pattern to it. You want to see red, where obviously there is good perfusion. In a case study here, where we had a patient come in, she just had some dizziness and some minor symptoms, and you find all this tumor effect. We know that they're going to want to do something as far as a surgical intervention quite rapidly, and our doctors made the decision to perform the MR perfusion on the spot. So here you have tumor effect, enhancement to it, but when you inject the contrast rapidly, you see the area of the bloody component of the tumor. But more importantly, what we do is we establish here, in this region, we establish the in the actual edema of the tumor itself, not in the actual mass, as compared to normal white matter. How much is that ratio? In this case here is 2.47 as compared to here. So if this was just 1, this number of vascularity was 2.47 times as high. Anything above 1.75 indicates hypervascularity. So you use the control as your, the normal appearing side, contralateral side, as your control, and then you calculate your numbers in your ROIs as compared to your normal control. MR brain perfusion. Brain infarction, and obviously with brain infarction you have that area of hyperintensity or hypervascularity. Hypoperfused tissue, slow-growing tumor, and again you have the comparison compared to hyperperfused. So hypoperfused and hyperperfused tissue. The hypo, not red. The hyperperfused is red based on perfusion data. In this case here, we actually changed the treatment plan based on perfusion data showing this tumor as low grade, only 1.17 compared to normal tissue. So a big difference in looking at that comparatively. 1.75, change the low grade to a high grade based on hypervascularity. And again, this is all based on microvascular changes of blood vessels. So excellent indication based on rapid dynamic imaging here, 2 to 5 seconds per dynamic acquisition. This is ultra fast rapid imaging. Tremendous diagnostic value if you have doctors, neuroradiologists especially, who are proficient in the interpretation of these studies. Arterial spin labeling, also known as arterial spin tagging, is an MRI method for measuring perfusion using the patient's own water molecules as tracers. ASL does not require the injection of gadolinium or any contrast material. Control images are acquired through the area of interest. Tagging pulses are applied to a slab of tissue upstream from the imaging volume that inverts the magnetization of water molecules in this slab. Next couple of seconds, most of these magnetically labeled molecules lying within the vessels will flow into the imaging volume. These tagged water molecules exchange their magnetization with those in the static non-moving tissue, reducing the latter's equilibrium magnetization slightly. Area of interest is re-imaged, and data from the tagged images are subtracted from the control taken prior on literally a pixel by pixel basis. So the final subtracted image is basically perfusion weighted. So now you have the control, you have your labeling, the time delay for the flow, and now it's tagged. So the control minus the tagged equals perfusion weighted. And obviously it's a little deeper than that. There's newer techniques where there are phase-based techniques. So these are the current generation of ASL techniques, and they result in reduced signal for flowing blood in tag slice relative to the control. PASL version named FAIR yields opposite signal intensity, whereas tissue in the control is suppressed, and inflowing blood has a higher signal than the background. PCASL uses a narrower band for tagging. We can combine this with functional MRI to evaluate regions of activation as an alternative to the BOLD technique, which stands for blood oxygen level dependent. So what is functional MRI? Speaking of the BOLD technique, the effect to obtain diagnostic information. So blood oxygen level dependent, functional MRI, one of the biggest research entities in all of MR imaging. You can assess for multiple functions: speech, motor skills, memory, pleasure, sensation. What are the applications? Tumor, stroke, research. Functional MRI was used to evaluate criminal, like serial killers, pleasure sensations, where normal people would look at pleasure as, vacations, friends, parties, good times, food. That would be me, right? Where you have all of these pleasure sensations, right? But in the criminal mindset, that switch that's really off, where when they look at pictures of dismemberment and death and dying and injury, that's where their pleasure sensation activates in their brains. This is all established by functional MR. Areas where we can establish activation. Patient that's moving the left finger, there are areas that are going to be activated during function. Pre-surgery versus post-surgery, the areas where speech is found. So if you do this pre-surgery, you're going to tell that doctor when they take out that tumor, don't touch these spots. So that post-surgery, their speech functions or functionality remains intact. This is a huge application. How about lie detector? Measuring the activity of the central nervous system, brain and spinal cord, rather than the peripheral nervous system as polygraph testing. We all know that most people can beat the polygraph test, right? But you can't tell the system, there's something in my brain that has to say, hey guys, my shirt is red today, right? And then areas firing off in where lies occur, as opposed to saying, hey guys, I'm wearing a tan shirt today, whatever I'm wearing. That's the area of truth that occurs. Of course, we know that, if somebody's going to try to beat this, they can always claim to be claustrophobic and not have to go through the functional MRI, right? One of the last advanced techniques that we use, we actually just had a patient scan today for this, is diffusion tensor imaging. So DTI, or diffusion tensor imaging, is taking your normal molecular movement of water, which is the definition of diffusion, right? On that sub-minute small level, and now you're looking at a greater detailed multiple directions. What defines diffusion tensor is how many different B directions are we going to acquire. And what you notice is these color maps that are activated here indicate directional water movement. So this blue indicates head to foot, the red indicates right to left, and the green indicates A to P. So that's all fine and dandy, but what does it really mean for you? You ever hear of tractography? Well, DTI, or tensor imaging, is looking at the fiber tracts. So the fiber tracts within the brain, and this is a huge application if you have a patient with, let's say, tumor, you have a patient with a mass, or some effect like that where surgical intervention can help the patient, but you want to make sure the doctor doesn't touch any active fibers, which will control function. So yeah, it looks great to have some nice color maps, but it's really important from a surgical intervention and surgical planning aspect. And of course, post-processing is always fun. This looks like the cover from, I think, a Muse album or something, where it's all this color mapping, great fiber tracks within the brain. An excellent opportunity for a detailed view or application of a tremendous value or diagnostic capability. I really think this is one of the most amazing views I've ever seen. Fetal imaging, doing diffusion tensor imaging with a volume rendered recon. Shaded surface rendering, take that off, and what do you have? The fibers inside a fetal MR. Really tremendous, great picture. One of the newest techniques over the last years, it's funny, this has actually been around for a while, and then it kind of went away for a while. Now it's kind of come back, and it's come back specifically for what are we looking to do here? MR elastography, very simply put, is a method where there's extra hardware of sound waves that are used to assess the stiffness of tissue. Have you done it with breast a little bit? Most commonly the application is used for liver stiffness, and especially in certain indications or certain conditions, MR elastography can be extremely beneficial for liver disease, for hepatitis conditions, things of that nature, where the stiffness and the elasticity can be just absolutely valuable with the diagnostic quality. Elasticity refers to the ability of a material to return to its normal size and shape after being deformed by an external force. This can be literally $100,000 to $140,000 in hardware and peripherals that are used to perform this function in addition to the software. So MRE is a technique utilizing shear waves to assess the stiffness of tissue. Seismic shear waves are detected using phase-sensitive MR sequences. As the tissues become stiffer, waves propagate more rapidly and produce longer wavelengths. Shear stiffness is reported in kilopascals, kPa, and definitely additional software and hardware capabilities. So the wave image, the elastogram, in a patient that's normal tissue versus a patient with fibrosis. The wider wave spacing in the fibrotic liver as compared to the normal liver. So the wider spacing is what indicates the stiffer tissue. Fibrotic tissue, fibrotic liver. MR cardiac. So MR cardiac is becoming a lot more commonplace than where it used to be very, very targeted and specialized based on location, experience, magnet. One of the things I want you to keep in mind is this poster right here provided by Philips Healthcare. You start off with an axial sequence. From that axial sequence, to plan this RAO in purple, you need this angulation here. Now off of the RAO, you're going to use this angle here to get to your semi-four-chamber. Then this is used to plan your short axis, then to plan your four-chamber, then to do the transverse RVOT, which gets you from the RVOT view to the pulmonary valve. You have your right two-chamber view, which is here. that comes from here that gets to your tricuspid. So all of these different chambers, outflow, chamber, outflow. This LVOT here is what gives you the LVOT view here, which gets you to your aortic valve. Key components to imaging the cardiac, but it takes so much time. Unfortunately, you have to go from plane to plane to plane to plane to plane, and then all of a sudden the patient has to go to the bathroom. So please instruct your patients before you start. It's already going to be a 45-minute to an hour 10 exam in almost every magnet. They have to use the bathroom before they start. You don't want them stopping here and then you got to go back to the beginning, because you need each plane to plan off the next in order to get to the next view or sequence. So let's take a look at it. Obviously, there are 4 chambers within the heart, and we want to image especially this view right here where we can look at the septum. We want to image out to the apex so that we can see the heart in good functionality. Always black blood anatomic sequence is important for us to assess the different chambers as we image throughout. So especially we have the left ventricle, we have the descending aorta, here's the septum in between, we have our right ventricle, here's our left atrium tucked behind here, and then the right atrium here. So our 4 chambers and then some. This is our 4-chamber view, one of the most popular views that we utilize in our imaging, because we're able to assess the mitral valve, the tricuspid valve. Here's your ventricles, here's your right and left ventricle, here's your right and left atrium, and then we're able to see the descending aorta, the apex of the left ventricle, and then again your septal wall. So a really excellent view, but we have to get to the short axis view before we can plan the 4-chamber. We don't get to the short axis view until we run the semi-4-chamber. So it's this trickle-down effect, this domino effect, where you don't want the patient to be moving. So our long axis here is planned off our axial sequence. Shimming is crucial in a cardiac MR. So it's really important for you to shim the heart and as little air as possible. You want to get the heart proper, especially the 4 ventricles included within that shim that you acquire. The semi-4 chamber is planned off of the long axis view, which is this right here, and we're going basically cutting through the valve and out to the apex there. Our short axis view is planned off of the semi-4 chamber, and we want to be basically perpendicular to the septum, and we want to go all the way out past the apex. So we want to be prior to or proximal to the valves, we want to be all the way out past the apex there. Segments of the left ventricle, the apex section here, the apical segment, the midplane, the basal, here's the mitral valve here, and the pulmonary vein. 4-chamber is planned off of the short axis. We go in between the papillary muscles, which are tucked in here, so the papillary muscles, down to the apex there. Good 4-chamber view enables you to see all 4 chambers. And then at 4 mLs per second, we want to rapidly, around mid-ventricle, right? We want to rapidly inject the contrast so that we can see the arrival and exiting, the entry and exit throughout the chambers. 10 minutes after the injection of contrast, we're going to perform what's known as the LGE sequence, or the late gadolinium enhancement. So 10 minutes is the earmark for when you want to acquire your post-contrast sequences. So at around 8.5 or 9 minutes, we're going to perform this look locker sequence, is what we call it. This look locker is going to tell us at various inversion delay time points, it's going to tell us about the nulling of the myocardium. So see this rounded circular structure here? So this rounded circular structure is the myocardium, and you want this myocardium to be nulled. So you draw an ROI, you copy it to all time points of inversion delays, and you run an intensity chart, that will tell you specifically what's the optimal inversion delay for you to plug in for your post-contrast. In this case here, around 300 milliseconds at the 307, nice dark myocardium, right? Here's where it starts to fade, so you don't want to be too long. We're going to plug that into our late contrast enhancement sequence. Our goal in our post-contrast sequences, our late gadolinium enhancement, our goal is to have this nice dark myocardium, and that's the way we get the most optimal images. So late gadolinium enhancement is what gives us the most optimal images through that region of interest. Other planes we can do, left ventricular outflow tract, and then the aortic Q flow would go off of that. So here's the aortic valve. The Q flow would be just distal to that, where they can assess speed of the vessel, blood flow, volumetric acquisitions. RVOT, straight down the middle, so that you're able to get a really good look, so that you can plan appropriately for your pulmonary Q flow. Here's the pulmonary valve, so the Q flow is positioned perpendicular to it. What did we talk about with phase contrast last week? White and dark regions indicating various phase magnitudes, both flow quantification, the detail that correlates to bright and dark signal, correlating to systolic and diastolic heart phases. So quantitative flow analysis is the phase contrast angiography sequence. Additional CPT code would be a cardiac MRI velocity flow when Q flows are warranted or asked for. In phase contrast imaging, partial volume effects may lead to an underestimation of flow velocities and thus flow volume. Velocity mapping and flow quantification by phase contrast will allow for a direct measurement of regurgitant flow going in the wrong direction. So comparing diastole to systole or systolic phases of the heart cycle and the changes within it. When we talk about cardiac gating, we're talking about utilizing the patient's ECG waveform, specifically that R-to-R interval, to trigger an MR sequence. This will help to minimize pulsatile blood flow and heart motion artifacts. The R wave peak is the point in the cardiac cycle that contains the greatest amplitude electrically and is therefore measured as the timing interval points with regards to calculating TR. Heart rate controls the TR, or termed the effective or available TR according to the beats per minute. If a patient has tachycardia, the R-to-R interval is shorter than a patient with bradycardia, the slow heart rate. Brady bunch or a slow bunch. So I drew up a quick slide for you to kind of explain the different segments of the cardiac gating waveform, the ECG waveform. The P to R interval, especially we're concerned with the R to R interval. What do you notice here? A lot of movement. This is obviously the beating of the heart. We really want to image. Ideally, what we look for is end systole to mid diastole. So we really want to image in this segment right in here. Because we don't want to just include from R to R, we'd have too much beating of the heart motion. There's methods that we can achieve this end systole to mid or late diastole opportunity of imaging. And how do we do that? Using a trigger delay and trigger window. But we have to start with our basic effective TR. The R to R interval will be calculated as 60,000 milliseconds. This is what we start with. How did I get that number, Chris? Good question. So 60 seconds per minute, there are 1,000 milliseconds per second. So that's 60,000 divided by the patient's heart rate, which is 60 here. That equals 1,000 milliseconds TR. Our patient with tachycardia, really fast heart rate, it's 100 beats per minute. So 60,000 divided by 100 equals 600 milliseconds TR. Patient with a really slow heart rate, 40 beats per minute. 60,000 divided by 40, 1,500 milliseconds TR. So the question I have for you, which patient, bradycardic or tachycardic, is the most difficult to achieve T1 weighting? Obviously the patient with the longer TR, so that's bradycardia patients. More difficult to achieve T1 weighting than to break them up into multiple packages. So with that TR, now what are we doing with it? We're adding on a trigger delay and a trigger window. Why do we do that? We want to wait the appropriate time frame for it to get out of those heartbeats. So we wait a period and then we create a window so we narrow down that period of imaging. So we're detecting the R wave before transmitting RF as the trigger delay. Trigger window is basically the waiting period before each R wave. And let's look at how that affects our imaging. So we're going to take that imaging time as the RR interval, and we're going to subtract from that R to R interval our trigger window and our trigger delay. So if we have a heart rate of 80, trigger delay of 50, trigger window of 10%, what is our available imaging time? So it'd be 60,000 divided by 80 equals 750 milliseconds. 750, we have to take off of that our trigger window and trigger delay. So our trigger delay is 50, that's here. Our trigger window is 10% of our 750, so that's 75. 75 and 50 is 125. Take that off of our 750 TR, we have 625 milliseconds of total available imaging time. So this is a better indication of how we are going to assess our available imaging time. We have our trigger delay, and then we're going to take that trigger window off the top of our R to R interval. So our available imaging time is basically tucked into here, away from the major motion of our heartbeats. So the trigger delay and the trigger window are subtracted from our overall R to R. So speaking of that, there are two ways that we can actually gate our sequence. We can use prospective gating, or we can use retrospective gating. One thing you notice with retrospective gating is that it's a continuous sampling of all your data, irrespective of R to R interval, beats, heartbeats, no beats, doesn't matter, right? Prospective gating uses an AR option to get rid of the main heartbeats. So prospective gating only basically acquires the data in this section here. So let's take a look at that. Prospective gating utilizes that AR or arrhythmia rejection of pausing the sequence data to allow variations in the subject heart rate. Prospective gating is most common because it's triggered by the heart rate. Retrospective gating is useful in patients with arrhythmias because data from the irregular heartbeats can be rejected. There's no trigger window and the full cardiac cycle is imaged. Imaging of the full cardiac cycle may result in more accurate assessment of cardiac function. Cine sequences collect data continuously during a cardiac cycle. So those cine images are going to be acquired within an entire cycle. And then you have multiple images acquired across these phases so you can see the heart in actual motion. And really that's the whole point and purpose of why we need, why we require, why it's so important for us to have the motion aspect. We need the rapid imaging. It has to be gated properly and appropriately, so that we can see the functionality within that acquisition. Most important sequence we do, take a look at the actual valves moving when they open and they close, and you see the movement of blood going in and out of chambers. If you see black, that's regurgitation, so that's flow going in the wrong direction. That was the aortic valve inside there. So you're seeing this functionality, if you will, the beating or the moving heart. That's a true or a really crucial aspect of the diagnostic component of cardiac MR. So really crucial aspects towards achieving the highest image quality possible. Appropriate and adequate gating is the number one means of achieving this result. That you can see valve opening and closing, functionality, movement, morphology, where you have the anatomic variants that are established throughout your image. So steady state free precession sequences are what enables the perfusion studies to detect ischemia and morphology, which is anatomic variants. Our late gadolinium enhancement, infarcted myocardium, right ventricular involvement, myocardial recovery. Our LV function is cine imaging at rest. We can also increase dosage of dobutamine or stress imaging until an age-predicted heart rate response is reached. Usually hospital settings would be what requires that. Short axis view is preferred for image orientation for ventricular volumetry, as it suffers from less partial volume effects. Flow voids from valvular regurg is a dark jet upstream. Morphologic assessment of cardiac anatomy, balanced steady state free precession sequences. Our free precession, bright blood and bright fluid are these sequences that we use to acquire those cine movements. So speaking of blood, blood is composed of formed elements, 45% volume, and plasma. You have all of these conductive elements within blood. So we're going to look at something called the magnetohydrodynamic effect. Very simply, T-wave elevation within the confines of the MR magnet, the MHD or magnetohydrodynamic effect, T-wave elevation inside an MR system. When you have the green inside the MR scanner compared to the red, green compared to the red, elevated T-wave that you see that occurs in the presence of an MR scanner. So here's the R's, they're okay, but the T-wave has a pretty significant swelling within the actual magnet itself. Why? Magnetohydrodynamic effect. Also these other names as well, but usually it's the magnetohydrodynamic effect. So what pathology are we looking at? As you see here, multiple densities. Does this look familiar to you at all? Susceptibility artifact, that's pretty significant. Think back all the way back to week 1. Cavernous hemangioma. Multiple densities within the same tissue component types can have some enhancement property to it. Cavernous hemangioma, a raspberry-like appearance, sometimes can have some venous drainage to it. Pathology that occurs on MR. Future of MR, I was just reading some RSNA stuff from the other day. Microagent contrast mediums or other agents that are not gadolinium based. Microcoils, unlimited digital channel receivers design. Just this week, GE came out with air coils, so lighter coils that aren't going to have the burn component to them. Flexible coils that go over patients, and really the imaging aspect behind that could be pretty tremendous. High resolution CPUs and recon algorithms. Gadolinium usage moving away from linear agents. The European Union Bulletin says macrocyclics only. MR fingerprinting is the wave of the future, basically setting that component and going from there. Compressed sensing. Low field imaging, recon or reconstructing in higher fields. Think of the DVD upconverters. I only have a 720p TV, but I'm upconverting to nearly 4K quality by simply just upping the resolution, reconstructing it higher. And then synthetic MRI. So one scan and all contrast. Take a 10-minute scan, you get your T1, your T2, your flare, your FATSAT, your anything you need within one synthetic MR. In fact, there's a lecture that's going on this weekend, I believe from AJNR or something, specifically talking about the synthetic MR techniques and the research and the development that's occurring with that. So MR has a great future. So glad you can kind of be a part of this, and that's all I have for you today. Thanks so much for watching.